Hello everyone, welcome back to the channel. Today we're going to be learning about part 2 of strokes and TIA. So firstly, an overview. A stroke is a cerebrovascular accident which precipitates a neurological deficit, an interruption to the blood supply to the brain. Typically there's a very rapid onset and it can cause oxygen deprivation to the brain, which can lead to ischemia, which is a lack of oxygen, or infarction, which is the death of tissue. The main causes of a stroke, especially an ischemic stroke, is a thrombosis, which is the formation of a clot that obstructs the vessel, or an embolus, which is the obstruction of a vessel via clot from a distant origin. Atherosclerotic emboluses can also particularly come from the vessels of the neck, such as the internal carotid, as it travels up to the brain, leading to oxygen deprivation in the brain, leading to ischemia, leading to a stroke. Other causes can include a watershed infarct or an intracranial hemorrhage, as well as shock. A stroke can usually lead to the loss of consciousness. Headaches can also be common, and it can also lead to other symptoms such as nausea and vomiting and seizures. A TIA is essentially a mini stroke. It's a transient episode of neurological dysfunction secondary to ischemia, but without infarction, which is the death of tissue. It typically lasts at maximum between 24 hours and resolves within 24 hours, and even sometimes typically less than within 1 hour. It's caused by a transient decrease in blood flow to the brain, and it usually happens around focal locations such as the brain, spinal cord, and retina. The top risk factors for stroke is cardiovascular disease, so examples include angina, myocardial infarction, and peripheral arterial disease. A previous stroke or TIA, as well as family history, can predispose and increase the risk of stroke in a patient. Atrial fibrillation increases the risk of ischemic stroke. Being on the combined oral contraceptive pill is also a risk factor for ischemic stroke, as well as other things such as hypertension, diabetes, smoking, vasculitis, and thrombophilia. Now, there are two types of stroke. There is ischemic stroke, which is much more common. About 85% of strokes present as ischemic stroke, and then hemorrhagic strokes, which is much less common. It's about accounts for about 15% of stroke. Ischemic stroke is caused essentially by a blockage in the blood vessel that stops blood flow. So the most common reason can be anything that results in an embolus, dislodging and causing a clot in the brain. So atrial fibrillation, which increases the risk of an embolus forming in the heart, can increase the risk of an ischemic stroke. Thrombus from large vessels such as the carotids can also increase the risk of ischemic stroke. And other general risk factors particularly include hypertension, smoking, as well as atrial fibrillation. Whereas with hemorrhagic stroke, it's more caused by a burst or a bleed within the blood vessel, which leads to a reduction in blood flow. It can be caused by other subtypes include intracerebral hemorrhage, which is a bleeding within the brain, or a subarachnoid hemorrhage, which presents as a thunderclap headache at the back of the headache in the occipital region, leading to a bleed on the surface of the brain. And risk factors for this, particularly also hypertension, arteriovenous malformation, and anticoagulation therapy. So we'd want to stop things like warfarin and DOACs if a patient has a hemorrhagic stroke. A stroke usually presents with a sudden and rapid onset of neurological symptoms. So we can remember these neurological symptoms with the mnemonic be fast. So firstly, balance. The patient may experience a loss of balance, headache, dizziness. Eyes, they can have blurred vision. Face, so a drooping of one side of the face. Arms, they can have motor weakness and also weakness of the limbs and the arms. Speech, they will have speech difficulty, so dysphagia and dysphasia, which is swallowing and difficulties as well as speech difficulties, as well as other neurological symptoms such as homonymous hemianopia, which is same-sided half-blindness on the same side of the visual fields. And therefore, it's really important to act as fast as possible because time really is of the essence when it comes to reacting to and responding to strokes. So there are different stroke patterns depending on the brain blood supply that's affected. So a stroke can affect the cerebral, the brainstem, and the lacuna. In a cerebral blood vessel, we'd also experience contralateral hemiplegia, sensory loss, and homozygous hemianopia, as well as dysphagia. In a brainstem stroke, you can experience quadriplegia and locked-in syndrome. And in a lacunar stroke, you can experience pure motor, pure sensory, mixed, or ataxia. And in terms of the presentation of a TIA can present with unilateral weakness, sensory deficit, aphasia, dysarthria, ataxia, vertigo, loss of balance, visual disturbances, amaurosis fugax, diplopia, and homozygous hemianopia. There are also 4 types of strokes, brainstem strokes. So the first one being, and this we usually classify this with the Oxford Bamford classification of strokes. So the 4 types of brainstem strokes are total anterior circulation stroke, posterior circulation strokes, partial anterior circulation strokes, and lacunar strokes. And this diagram basically shows how these would present. So in a total, you get 3 of the following signs listed. In a partial, you get 2 out of the 3 of the signs listed. In lacunar, you only get 1. And in a posterior circulation stroke, you get 1 of the 3 signs listed. There's a range of scoring systems that we can use to recognize stroke in the emergency setting. The first one being the Rossier classification system. So we can look at things like if the patient has had a loss of consciousness or syncope, seizure, asymmetrical facial weakness, asymmetrical hand weakness, asymmetrical leg weakness, speech disturbances, and visual field disturbances. Any score greater than 0 means a stroke is likely, and a total score of -2, -1, or 0 means a stroke is unlikely. It's really important to also exclude hypoglycemia because this can be a differential and present very similarly to a TIA or stroke. Now, the Rossier sign is useful in the recognition of stroke in the emergency room and is a clinical scoring system based on these various of clinical features and durations. And then another one that is quite handy in diagnosis and scoring of TIA is the ABCD2 score for TIA. Although it's not really recommended by NICE as much anymore, just for context, A would stand for age, so a patient would get a point each for each of the following: age over 60, a blood pressure over 140/90, clinical symptoms of unilateral weakness or speech impairment without weakness, a duration of greater than 60 minutes or 10 to would get you 2 points, 10 to 59 would get you 1 point, and diabetes or being on medication or insulin 1 point. And a score greater than 5 means that a TIA is likely. In terms of imaging, we'd want to do if any of the symptoms of stroke is presented and we suspect a stroke, we'd want to do an urgent non-contrast CT to distinguish between hemorrhagic stroke and ischemic stroke, as this will inform the management pathway we want to take. On the images below, you can see on the left there's an image of an ischemic stroke, which would present as a hyperdensity in grey and white matter, and maybe signs of an arterial clot. And then on the right, you see a sign of a hemorrhagic stroke, which would show as areas of hyperdensity surrounded by hypodensity or edema. If we are suspecting a TIA in any way, we'd want to, in preference, use a diffusion-weighted MRI. Now, the management of the different types of stroke and TIA can then be informed based on the diagnosis. So in terms of stroke, firstly, we'd want to do a non-contrast CT head to distinguish between an ischemic and hemorrhagic stroke. We'd also want to admit the patient to a specialist stroke centre and exclude hypoglycemia by looking at things like their blood glucose, their hydration, their oxygen saturation and temperature, to ensure that it's maintained within normal levels. The CT head should be done within 1 hour to exclude any primary intracerebral hemorrhage. If the intracerebral hemorrhage is excluded and the patient presents within less than 4.5 hours, we'd want to immediately do thrombolysis, which is IV alteplase, because alteplase is a tissue plasminogen activator, and that would help to rapidly break down any clots, and it can also reverse the effects of stroke if given in time. But it needs to be provided within the defined window of opportunity of 4.5 hours. And the patient must not have had any previous intracranial hemorrhage or any uncontrolled hypertension, as this could contraindicate the thrombolysis. The patient will need to be monitored post-thrombolysis to ensure that there are no complications such as intracranial or systemic hemorrhage, and this includes things like repeating the CT scan and things like that. We'd also want to provide aspirin 300 micrograms either orally or PR once daily for 2 weeks. If the patient can't tolerate it orally, for example, their airway is compromised or they're unconscious, we want to give it PR, and clopidogrel 300 micrograms, PO stat, then 75. And then we'd also want to then consider mechanical thrombectomy and transfer to the stroke ward, where we'd do the following aftercare to ensure the full recovery of the patient. And in terms of TIA, TIA is essentially a mini stroke which lasts less than 24 hours. So the patient should be immediately referred to a stroke specialist within 7 days. They should be seen, and if they've presented after 7 days, then they need to be seen ASAP. We would want to assess using the ABCD2 score, and immediately if we are suspecting TIA, we'd want to start them on aspirin 300 micrograms daily, unless there are contraindications. For example, they're taking an anticoagulant for a bleeding disorder. And if they are taking anticoagulant therapy, they must be admitted immediately to exclude hemorrhage and continue to be seen by a specialist. We'd want to review them with a specialist within 24 hours. And then we'd want to also consider carotid endarterectomy if the patient has any of the following, which is an ipsilateral carotid stenosis over 50% of the NASCET criteria or over 70% of the ECST criteria, if they're on any long-term drugs, if there are any other possible investigations, such as an ECG, a 24-hour tape, an echo, a bubble study for patients with a forearm variculae, and vasculitis screen and thrombophilia for screening. Now, in terms of the secondary prevention of stroke, to remember the kind of drugs that we need to give to ensure secondary long-term prevention, I like to use the mnemonic HALT. So H for hypertension control with ACE inhibitors, antiplatelet therapy, so aspirin 300 micrograms of clopidogrel, 70 micrograms. Alternatively to clopidogrel, we can also give dipyridamole 200 micrograms twice daily. Lipid-lowering therapies, so atorvastatin 80 micrograms. Tobacco control, so put the patient on smoking cessation, control their sugars with diabetic medications, and also surgery, so patients with carotid artery stenosis should be considered for carotid endarterectomy or carotid stenting. And in terms of, we also want to modify any risk factors like hypertension and diabetes. After that, once the patient had a stroke, they may require a period of adjustment and rehabilitation. And rehabilitation is really essential to stroke care, and involves a multidisciplinary team approach of nurses and dietitians and occupational therapists would essentially want to help the patient to recover back to their essential state and provide secondary prevention to prevent further strokes. Thank you. I really hope you enjoyed this talk. If you have any questions, please comment down in the comment section below. Thank you so much.